From Yellowhammer News, this is One Day at a Time, presented by Longleaf Recovery and Wellness. Join me, Laurie Dhue, as I speak with industry leaders about the challenges and solutions surrounding substance use disorder and mental health issues facing so many people here in Alabama. Hi, everybody. Welcome back to another episode of One Day at a Time, where we're putting a priority on having important conversations about substance use disorder and mental health in Alabama. I'm your host, Laurie Dhue, and I have 17 years of continuous recovery. I want to give our listeners a bit of good news before we hop into today's episode. Positive news coming out of the CDC the second week of November of 2024. U.S. drug overdose deaths are falling. The country is on pace for its first year with fewer than 100,000 overdose deaths since 2020. So it's a symbolic milestone. It's powerful. It's also pretty bleak, of course. But here are the numbers. According to the Centers for Disease Control and Prevention, reported drug deaths fell nearly 17% during the 12-month period ending in June of 2024. Now, the epidemic's toll remains huge, but that number, this new number of about 93,000, is substantially lower than the 111,000 lives lost to overdose during the 12 months ending in June of 2023. Fentanyl contributed to a large majority of those deaths. The study also indicated that while drug overdose deaths have been trending downward for the last few months, public health officials are cautioning that this decrease may represent just a data blip and not a genuine shift in the public health of the nation. The study cited the increased availability of harm reduction resources like fentanyl test strips, as well as efforts to immediately connect victims of non-fatal overdoses to longer-term addiction care. And since the COVID pandemic, methadone and buprenorphine, two long stigmatized but highly effective medications used to treat opioid addiction, have become easier to access. Joining us today is Dr. Joe Lucas, a psychiatrist and president of Grayson Associates, a behavioral health practice in Alabama, treating all types of patients for psychiatric and behavioral health disorders. Dr. Lucas, thank you so much for joining us today.
Thanks for having me.
Pleasure to have you here. You are a busy man and you do a lot to help a lot of people. So first of all, if you could tell us what kind of services Grayson Associates offers, and are you all over the state of Alabama?
We have 6 offices located primarily in central Alabama, and we provide services for anyone aged from, we actually see a few infants and their moms all the way up to late geriatric issues. So we see people at all stages of life. We see folks who have all sorts of behavioral disorders, psychiatric disorders, anxieties, worries, stresses. Sometimes people come to us and they don't even know what's going on. They just know they feel uncomfortable. And so we evaluate those folks with physicians, nurse practitioners, therapists, psychologists, and we provide them wraparound services to help with all of these types of disorders to help them get back to their healthy state of being.
You got my attention when you said that sometimes you see mothers and infants. Tell me about that.
Well, we get calls from ministers, we get calls from obstetricians, and sometimes moms themselves who call and say, I just don't feel right after the birth of my child. And so we get them in and see them. Many of us also see people in the hospital, and so we'll see folks who are 2 or 3 days after the delivery of their child, and we see people for baby blues, for postpartum depression, postpartum anxieties. We'll also see, rarely, because it's a rare disorder, but there's a condition called postpartum psychosis, where a young mom has had a child and has developed delusions or hallucinations subsequent to the birth.
I'm really glad you brought up postpartum issues. We know how serious they can be, and they're on the table now. People have been discussing postpartum issues, fortunately, now for decades. But back in the day, there wasn't a name for it. But now there is. So kudos to you for addressing these issues and helping moms and families, because I know sometimes the dads don't always understand what's going on either.
That's true. And education often helps to normalize the situation so that when you put a name to something and you explain that they're not alone, this isn't the only time that that this has occurred, it often helps people to navigate that situation. The unfortunate part of this for many young parents is that they feel some stress and they feel that they are being pressured to be happy because of the birth of the child, and yet they don't feel happy. So it leads to even more grief, even more anxiety, even more worry than they would otherwise.
Right. So you have this new, beautiful member of your family, and yet I don't feel perfect. I feel far from it. I'm stressed out. I am supposed to take care of this infant who's depending on me. You can understand why this causes so much anxiety in a time of joy.
That's correct. And we also have evidence that it's greatly hormonally generated. And so it isn't that there's something wrong with you or it's a character flaw or that you're just not a good enough parent. It helps them to understand that these are biologic changes that occur that lead to these mood states.
You also mentioned that you have geriatric clients. First of all, what constitutes geriatric? 65 plus? Or a little bit older? I mean, as we all get older, we think, wait a minute, am I getting to be geriatric?
Yes, I'm 60 years old, so I am looking at square in the eye. Generally, it's 65 and above. That seems to be the arbitrary cutoff for the beginnings of the geriatric life experience. But there are people that we know who are experiencing some of those issues prior to 65. And then we have other people that seem to sail very easily into their 80s before issues can occur.
And when you say issues, I'm guessing depression, isolation, death of a spouse that causes these feelings of maybe the isolation and depression and sadness and sort of my life is coming to its end in the next 10 years, 15 years. That sort of thing?
That's one of the things that we see. We certainly see significant amounts of depression. I tell people as they approach their retirement from their employment life that they need to be prepared because it is a change. And for most of us who have worked for substantial periods of our life, you need to have the skills that are there so that when you transition from a working person to a non-working person, that you don't feel isolated, alone, and without purpose. We also see a lot of people, unfortunately, who have dementia. And that is as we all know, that's a very common illness as we get older. Some people also have high levels of anxiety as they get older. Many of our elderly patients that we see because of just in economics, et cetera, their kids who are now adults have moved across the country. And so mom and dad are left here. And sometimes that can be very anxiety provoking as you get older.
Yes. And there's the fear of economic insecurity. Do I have enough retirement money saved up? And if I don't, then what the heck am I going to do? I can't just rely on Social Security. That must be a concern as well.
It is. It's a very common concern.
Mm-hmm.
And and for some people, even though their families, maybe their financial planner, et cetera, say you're fine, they just aren't sure they trust that's exactly true.
Something that I am also noticing is that older people are not immune from developing substance use issues. I can think of a couple of people I know who developed alcoholism and an addiction to pills in their 60s. So this is one of your top areas of expertise. Could you speak to that for a moment?
It is probably the one age group where the substance dependence and substance use disorder rates are increasing.
Oh dear.
It has become problematic, and it really kind of became clear during the COVID isolation that the rates of alcohol use, anti-anxiety medication use, opioid use all climbed across the board, but it really seemed to accelerate in the 60-year-old plus age groups. We were also seeing a significant number of the baby boomers who may have used cannabis in their teens and 20s who are now coming back to it as we've gotten this mixed message that cannabis is okay, cannabis is safe, cannabis is not safe, we don't know, it's legal, it's not legal. We're seeing higher rates of cannabis use than we've ever seen in elderly people.
So let me ask you something. We know that the human brain is developed by the age of 25-ish, right? So if you are 75 and if you are in pain, is it not a better option to take a cannabis gummy than to get on pain pills?
That is a complicated answer. And certainly it depends on what you mean by pain pills, because there are pain pills that, like opioid derivatives, that are particularly dangerous in terms of falls,
yes,
dependency, cognitive impairment. You have others that are less so, that are probably safer, but they have their own set of issues, such as ulcers. You can have brain bleeds, et cetera, from those. So nothing is free of side effects.
Right.
Cannabis is problematic for older people because it too reduces your short-term memory. It reduces your ability to use muscular coordination, which becomes more difficult as we get older. So it increases your fall risk. The one difference between cannabis that makes it slightly more problematic than even regular pain pills is that because it is fat soluble, it tends to hang around for a long period of time. So when you use some cannabis today, it may be in your system for the next 30 to 40 days.
Oh, gosh.
As opposed to a regular pain medication, which may be out of your system in 6 to 8 hours.
And there also is the danger that THC concentrate in some of these gummies is extremely high. And it's often not regulated unless you buy it in a cannabis dispensary. In the state of Alabama, cannabis is not legal. So I suppose that Alabamians could get it if prescribed by a doctor. But we have to be very careful with this.
Well, we do now have a medical marijuana law.
Right.
Unfortunately, though, it's been backed up in court. And so there are no dispensaries. And even for the physicians, and I actually took this test myself, where you take a class and you pass a test and then you have the ability to prescribe it, but there's nowhere to prescribe it. There's nowhere for people to get the cannabis.
Right.
So, because again, it's in court.
Right.
Medical cannabis, medical marijuana have much lower rates of THC than typically you find on the streets. So that I think will make it somewhat safer than just getting it from your local dealer. The other issue that we have in the state of Alabama is that while cannabis is illegal, we have these Delta 8, Delta 9 cannabinoids that you can get from lots of places. And that affects people in very unpredictable ways. And there is not a lot of oversight and regulation of these substances. So people are getting various levels of these intoxicants.
And where are people getting Delta 8, Delta 9?
You can get it from regular cannabis stores. You can get it from health food stores. You can get it from some
health food stores here in Alabama.
Yes.
Okay. Well, that's obviously very concerning.
It is to me. Now, I recognize that the federal law allows for the sale of hemp products, and that's how these get around the cannabis laws. I'm no lawyer, but I think that's how these places are able to sell this legally.
Look, there are ways around everything. If you make these products, I guess you hire a team of crack attorneys and you say, okay, this is how we're protected. How did we get to this point of opioid dependence where we have become, and I do think it's getting better, but if you could speak to the origins of opioid dependence in this country and how we got here.
Well, opioid dependence has been around as long as humans have probably been in existence, and were able to find plants that provided some type of opioid type of poppy.
In other words, thousands of years.
Yes. And so we've always had some level of dependency on these substances. The most recent issue seemed to have occurred with the start of long-acting opioids, the OxyContins of the world, that were promoted by the companies that made it, the drug reps, the federal government, that said that pain was grossly undertreated, and that the use of these long-acting opioids was part of the key to treating pain more appropriately. And the message that was given to physicians and to patients was that if you use these appropriately, that the risk of addiction and dependency was quite small, and that, in fact, if you felt that you needed more of these substances, that you were just trying to get adequate pain control, not that there was some level of dependency issue that was occurring.
Oh my gosh. Well, look, you mentioned the word appropriate. A person who is starting to take these pills cannot regulate on their own what is appropriate and what is not appropriate, right? So therefore, look, I blame a lot of people for this. I'm so angry about this. I mean, I think we all are. These big pharma companies, they have blood on their hands. They know it. They've handed out billions and billions of dollars in settlement money. So they know. We have a whole generation of people who got addicted to and died from their addictions. So people cannot regulate what's appropriate and what's not. If you could just speak to that part of it and how absurd it was for these doctors to think, it's okay, I'll just keep prescribing these for you. And, you just keep taking them. I'll keep prescribing them for you, and you'll decide when is enough for you.
It's correct. Pain is a very personal feeling. You can't look at somebody and know how much they're in pain. You can't get an outward measure of that. So to a great extent, you need self-report for the patient. There are some physical signs such as grimacing, tensing, things like that you can look for that say, okay, well, this person's having more pain than somebody else, but it's a very relative scale. I think that all of us who treated patients for pain kind of got swept up in this idea that physical pain has to be eliminated, and that it's not it's the patient's right to have total elimination of physical pain.
And that's not realistic.
It's not realistic, because in anything in life, we do what's called a risk-benefit analysis. In medicine, we do that all the time. And so what everyone was told was the benefits far outweighed the risk. Well, we have found out over time that the opposite was true, that the risk far outweighed the benefit. And so we have come to this conclusion that what we did was wrong, because we thought that people would be better off, when we have actually found that we unleashed this epidemic on our country. And unfortunately, too, I was on one of the boards of the hospitals, one of the local hospitals here at a time when this was all occurring. And one of the ways that the government would measure quality of healthcare was through pain control. And they actually used a term called, it was the fifth vital sign. And so if you did not totally treat the pain, then you were dinged in your evaluations.
Were you considered a failure as a doctor if you did not manage pain?
Yes, you are. You were graded poorly, to say the least.
That is so I mean, I'm sorry to be unprofessional, but that just sounds crazy.
Well,
it's okay. I'm not asking you not to be.
I think that the government, the doctors, the patients were all sold a bill of goods that turned out to be wrong. And so it took, unfortunately, the evidence of death to change the way we thought.
I guess the good news now is that doctors are only giving, 3 days worth of meds for the most part?
That's generally the case for, again, post-operative pain. Now, we do need to kind of clarify that for somebody who's got chronic pain that is certainly end stage for somebody's life, that's a whole different risk calculus that you take. But for people that have acute pain, then 3 to 5 days at the most is about all that's prescribed.
But the problem now is that the street filled the void when doctors stopped prescribing, right?
That's correct. For many of our patients who had been on prescribed narcotics for years, suddenly their physicians were saying, I need to taper you off of this. I need to stop this. This is not in your best interest. Our patients, many of our patients understood the risk benefit, went along and may have been uncomfortable for a while, but understood that the benefit far outweighed their risk. Unfortunately, some did not see it that way, or they could not tolerate the coming off of it. And even if they did, they had a lot of hunger and desire for those drugs again, which can occur when the brain changes from chronic opioid use. And so, yes, drug dealers stepped in and provided these substances at a very cheap price.
Thank you to our presenting sponsor, Longleaf Recovery and Wellness. Longleaf Recovery and Wellness is elevating the standard for addiction and mental health treatment in Alabama, offering exceptional and personalized care at centers in Birmingham, Huntsville, and Baldwin County. Life-saving programs offered at Longleaf provide a path to real change and support for a restored life long-term. Learn more about Longleaf Recovery and Wellness at longleafcenters.com. A big thank you to our sponsors, Blue Cross Blue Shield of Alabama and Southern Ketamine and Wellness. Then we have what I call the other F word, fentanyl.
Yeah, fentanyl got added about 7 years ago, and it started in China, and as a way to cut the drug. Fentanyl is very cheap. It's very addictive. It doesn't take very much of it to addict someone, to get them dependent on whatever substance it is you're selling.
I think you told me that fentanyl addiction can happen almost immediately.
It can be 1 or 2 doses, yes.
1 or 2 doses?
Yes.
The first time it could happen.
That's correct.
That's incredible. Yeah. So just to explain to our listeners, fentanyl powder is made in China for the most part. Then it gets shipped mostly to Mexico, to the drug cartels, the biggest one being the Sinaloa cartel, from my knowledge. And then these cartels package them up in pretty little packages and pretty little pills that look just like Xanax, Adderall, etc. And then they come across the border so easily because the pills are so tiny. And then that's how they get into this country and in the hands of basically anyone who wants them.
That's correct. Now, I have read, and again, this is outside of my lane, but I have read that the Chinese government has done a reasonable job of trying to tamp that down. But unfortunately, the drug cartels in Mexico learned the formula, which is quite easy, to synthesize fentanyl on their own. So it didn't really stop the flow.
And it's so cheap, and it's making these cartels even richer. So they're certainly not going to stop.
That's correct. And it also addicts the person much quicker. So if you've got a sometimes drug user, maybe that turns them into a very frequent drug user.
And a better customer purchasing the drugs.
That's true.
Right. So fentanyl becoming an issue the last 6-7 years. And what's terrifying is that someone may buy, and I'm thinking about young people especially, who are buying drugs on TikTok and Snapchat. Or anybody purchasing pills. They don't know where they came from. They take a pill, it has fentanyl in it, and they die. If you could speak to that.
Well, that's the problem for a lot of the sometimes drug users who think they're getting one thing when in fact they're getting fentanyl. The drug stamping process makes them look just like the pill that you might get out of your bottle if you got it from a pharmacy. Even the local drug dealer may or may not know what they're giving to their customer. And so the person gets it, they're naive to any opioid, and just a small amount can lead to respiratory depression and either severe illness or death.
So it's hard to identify, even if you get it from a so-called trusted source.
Correct.
Right.
Yeah.
And that's the danger of it.
Right. Because it looks just like everything else that you might take.
Would you say that it's important for every household to have Narcan? Every household, every school, every place of work to have Narcan around?
I think it's imperative to do that. Certainly, I know a lot of the local bars have started handing it out when you come in. A lot of the local music festivals, a lot of the concert halls offer it when you come in. Not because they're saying, yeah, you're a drug addict, you need to take this because we're worried about you, but because you don't know what's going to happen to the person standing next to you. And just a little squirt in their nose may actually be all it takes to save their life. It has no real danger. You can give somebody who hasn't used opioids Narcan. It's not going to hurt them. It's cheap. The government has made it basically free. If you offer it out and you don't have to get a prescription, you can walk into any pharmacy and they'll give it to you. And so, yes, I think anybody that has it, and certainly if you've got kids, it makes perfect sense to have it available.
Right. Often I hear the argument, well, if I keep Narcan in the house, then I'm giving my child permission to use drugs. When really, you're just a smart parent. You are a prepared parent. Because it may not be your kid. It may be the group of friends that your kid brings home. And you don't know who's doing what in your kitchen or in your basement. And if you don't have the Narcan at home and someone dies, you may be held responsible for it.
Well, that's certainly possible. I've got 3 children of my own who are all adults. They all went through their teenage years and they mean well. Teenagers mean well. They want to do the right thing, but they're also still very impulsive. Their brains are not developed to the point where they make good decisions. And so they may do or say things in a situation that they wouldn't ordinarily do or say, and that may involve just taking a particular substance.
So let's go back to opioids and treatment. I am a person in long-term recovery from addiction, and I know that treatment works. For me, it was about seeing a doctor, a medical doctor. It was about going to 12-step meetings, which I still go to almost every day of my life. And it was about having a community. But sometimes it takes more than that. Sometimes it takes MAT, medication-assisted treatment. If you could talk a little bit about that, why it used to be so controversial and why it's not so much anymore.
So medication-assisted treatment involves the use of a prescribed medication in order to help with cravings and to help with withdrawal. These medicines have been around for a long time. They've been around since the late 70s, early 80s. It really weren't used very much, and I think that comes from a antiquated way of looking at addiction as being a character flaw or a character disorder, that somehow you need to tough it out, and there's something therapeutic about that if you do it the hard way and you don't take medication and things like that, that somehow your recovery is going to be better than somebody who does it with these medications.
And that is what old timers say. They don't approve of replacing one drug with another. That's what they say this is. But it's, I like to liken this to a woman who says, I don't want anything when I'm giving birth. And, what you hear is that it doesn't make you any less of a woman if you decide to get an epidural during birth. So why the change? Why do you think that it's becoming more acceptable now?
Well, I do believe that we've seen a lot of death. And a lot of my patients who use medication-assisted treatment have unfortunately lost friends, family members themselves. And so there is a level of urgency that maybe wasn't there before the opioid epidemic occurred. I also think that there's been more education about the fact that these are brain disorders, and that when you use an opioid for even a short period of time, it changes your chemistry in your brain. And those changes in the chemistry of the brain, they don't just go away because you stop using the drug. They stay, and they lead to hunger for the drug. They lead to irritability. They lead to depression. They lead to a desire to get that substance and maybe do and say things that you ordinarily wouldn't do or say in order to obtain that substance. When they use medication-assisted treatment, they recognize that those sorts of things go away, but they don't get high. They don't feel high. They don't seek out the Suboxone. They don't seek out the naltrexone that they may be using chronically to help with opioid dependence. They just feel better. They don't hunger for it. They don't think about it. They don't obsess over it all day long. So they're able to have jobs, be part of their family, raise their kids, and, not spend hundreds to thousands of dollars a week on their substance.
Right. And when we were chatting earlier, we were talking about how Suboxone and naltrexone can help focus someone's thoughts from using drugs to more productive things.
Correct. The problem when you are in a state of craving is that's all you think about.
Right.
That is it. That's the only thing that comes to mind. You are focused on getting your substance, using your substance, and then at the end of that, when am I going to get my next dose of substance? So this allows you it frees your brain up and therefore frees your mind up to do the things that we all want and need to do every day.
Something that's important to you is treatment availability. I mean, I think it's important to everyone who is involved in mental health and substance use treatment world. We all are fighting for more treatment availability. So we know that the DEA has been pushing for this, the FDA has been pushing for it. But you said you were encouraged by the fact that legislators are now pushing for this.
That's correct. The approach has been in the past that you had to jump through quite a few hoops as a prescriber in order to prescribe these types of medicines. Not so much naltrexone, but Suboxone. Those hoops have to a great extent been removed. And so anyone who feels that it's appropriate can now write that prescription to help a person. The legislature in Alabama, the legislature nationally has really pushed for more availability for these medications. Even the insurance companies, which were slow to come to the table, recognized that it was in their best interest and their insured best interest to have these available at relatively low or no cost. And the cost of the drugs have come down dramatically also as the pharmaceutical companies have recognized that it's in their best interest to provide these at a relatively affordable rate. So yes, I'm a big believer in it. Right now, one of the pushes for the in Alabama amongst the Alabama Medical Association is to get more people on board to prescribing these medications. And so anytime you can catch someone at the point of crisis and get these things started, your chances of getting someone at a better place in life is improved.
That's the outcome we want for everybody, to get people to a better place.
Correct.
The follow-up to that is, to what extent are you encouraged by the fact that we, as a country, and even here in the state of Alabama, we're starting to normalize substance use disorder as just part of the human condition, something that affects almost every family?
I am very encouraged. I think that we are seeing more media contacts where they talk about substance dependence in the same way that they talk about diabetes or heart disease or arthritis or other long-term chronic illnesses. It's not being kind of pushed aside as a character flaw or a character disorder, that it's really being seen as a illness just like any other chronic illness that can have relapses, remissions, and we work in seeing it more as disease management model.
Yes, people make that comparison to diabetes a lot. What I always say is, if we see an overweight person eating cake, do we shame them? No, we don't. Do we go up to them and say, you probably have diabetes, I can see you're overweight. You shouldn't be eating that cake. We don't do that. And yet that's what we do to people who struggle with substance use disorder. And, that really sticks in my craw. So I'm glad that we as a country are talking about these things and are normalizing these discussions and encouraging therapy and counseling and making, helping people to understand that they can make healthy choices.
It's funny that you bring up diabetes. One of the things that I tell my patients is when they bring up the fact that, well, I don't want to replace a drug with a drug. They say, well, when you have diabetes, you are actually replacing the insulin with insulin.
Right.
So
good point. So when we were talking earlier, I said, what keeps you up at night? What are the things that concern you? And you said caregiver fatigue. If you could talk about that for a moment.
When I see a person who comes in who has opioid dependence, or for that matter, any other type of substance dependence or substance use disorder, when I see them early in the stages of recovery, many times they come in with several family members who are caring, loving, supportive. Unfortunately, because this is a relapsing, remitting condition like other chronic illnesses, it can be very discouraging over time to many of the people who are helping to care for this person, because there may be relapses even under the best of circumstances. And for people who don't have substance use disorders, it seems very illogical to use a substance that obviously is destroying your life. And so it can become very frustrating to that caregiver, and it can induce anger, frustration, irritability over it. And so they tend to become tired, become discouraged. And so many of them will slowly peel away. And the person who is trying very hard to get into recovery and get their life back on track may feel isolated and may feel forgotten, and that others have given up on them. So that's really what keeps me up at night, because that's really what tends to, unfortunately, lead to regression in many of my patients. Because if a person feels bad about themselves for having a substance use disorder and making bad decisions because of their substance use disorder, the family members who profess to love them and care for them have had enough, so they walk away. Maybe they care about them, maybe they love them, but they can't do it anymore. That reinforces the patient's perception of themselves as a broken, bad person, which unfortunately also can drive up the desire to use.
And then it almost exacerbates the shame and the guilt.
Correct.
And I say all the time, no matter where I'm speaking and to whom I'm speaking, that shame and guilt and stigma have no place in this conversation. And yet when there is that fatigue of dealing with the family member who's been struggling for months or years, you can just become completely exhausted and frustrated by that person. And you just want to give up. And you're right. So many people do give up. So what do you recommend for frustrated families? What can they do?
Well, the first thing I tell them is that it's normal to be frustrated. They love this person, they care for this person, but it's normal to be frustrated and be upset, because the decisions that are made oftentimes lead to more problems. I usually direct them to things like Narconon, Al-Anon, which are support organizations for family members and loved ones of people with addiction. And they can get some support there. They can also hear that the road they've traveled is a road that other families have traveled before. And so they can recognize that people have survived those ups and downs, and that there's life on the other side. And they also can see people who are at the early stages and help to provide them some support And that can be very helpful in your own life when you help people that are at the early stages of recovery.
I think one of the most important messages is you are not alone. I remember walking into my first 12-step meeting and thinking, oh my gosh, I'm the only person in the world who feels this way. And then I walked into the room and there were 50 people just like me. And it was so reassuring to know that I was one of millions and millions. My final question to you, Doctor, why do you do what you do? It ain't easy. It ain't fun. So why do you do it?
Well, I really love the brain. I love how the brain manifests itself through emotion, through behavior. I have always enjoyed people's stories. I have enjoyed the process of watching a person over time who comes in a crisis and improves and goes on and lives the life that they want to live. Our treatments are very effective. They're much more. I've been doing. I'm old, so I've been doing this since 1990. Our treatments have progressed to the point where we have much better response rates, much better remission rates. Our side effects are much less. We have learned so much about the brain and behavior and the connection between the physical and the psychiatric and the mental. And it's just it's a great field. And every day I see something interesting and I still get surprised. So.
I'm sure you do. And God bless you for what you do, because you're helping so many people. Dr. Joe Lucas, psychiatrist and president of Grayson Associates, thank you so much for joining us today.
Thank you so much.
Thank you for listening to One Day at a Time, a Yellowhammer News podcast presented by Longleaf Recovery and Wellness. Be sure to follow Yellowhammer News on Instagram, Facebook, and X. And follow me, Laurie Dhue, on Facebook and Instagram.